Please take your seats. I'd love to introduce our next speaker. Dr. Alicia Roth is a clinical health psychologist and staff member at the Cleveland Clinic of Sleep Disorders Center and is board certified in behavioral sleep medicine. She completed her doctoral training at the University of Florida, an internship at the Baltimore VA, and behavioral sleep medicine fellowship at the Cleveland Clinic. Her clinical work focuses on treating a range of sleep disorders, including insomnia, circadian rhythm disorders, central disorders of hypersomnia, and nightmares. Dr. Roth's current research focuses on the implementation of population health initiatives for insomnia treatment, as well as developing treatments for central disorders of hypersomnia. In 2022, she was awarded the Society of Behavioral Sleep Medicine Early Career Advocacy Award. Thank you very much.
Thank you. Thank you all for having me. So happy to be here. This is a great conference. It's so unique to be able to talk to not just fellow scientists and clinicians, but other stakeholders, including patients and their families and their supporters. So thanks so much for having me. Today we're going to talk about an opportunity, I think, for growth in the field in terms of helpful treatments for central disorders of hypersomnia. And we're going to talk about a very popular treatment in psychology and mental health, but one that you may not have heard before, called acceptance and commitment therapy, or ACT. So we know from research, and you know from your experiences, that psychosocial functioning in people with CDH is terrible. Just the experience of getting to a diagnosis, the length of time, the misdiagnosis causes a lot of distress. We know from research that people with different with different types of hypersomnia are more at risk for psychiatric diagnoses. The stigma of having these conditions are very high. There is research that shows that negative self-esteem is very prevalent, and that relationships are often, as we've talked about in this conference, relationships are often strained or difficult to make. And there are definitely occupational problems in school or work. All of these things have been supported by research. It's not just anecdotal evidence coming from the community or from the clinicians. We know this through research. But that being said, I think that there's a dearth, there's a lack of information, or there's a lack of treatments, scientifically supported treatments to address these things. Because as Dr. Scammell was talking about, the pharmacological interventions have really exploded, in the past decade, and are continuing to move fast, and that's wonderful. And of course, those pharmacological treatments are miraculous in terms of the degree to which they can control symptoms, but they do not necessarily address at all these problems. And for patients that I work with who have either narcolepsy or IH, we'll talk about, if this goes away tomorrow, if it's cured tomorrow, you're gone, it's gone. The narcolepsy is gone, the IH is gone. You still have the aftermath. You still had the experience of having it. You still had the strain in your relationships. You still had the problems at work or school. You still had the loss. And so I think addressing the experience is just as important as addressing the symptoms. No, there's a great series of studies several years ago with Jason Ong's group from Northwestern at the time, that include Dr. Jen Munt, who you saw speak yesterday, that developed what we call CBT, cognitive behavioral therapy for hypersomnia, which is an adjuvant treatment for hypersomnia disorders to improve psychosocial functioning. So they did a series of experiments to try to identify the needs of the population. So the first, they did a survey asking people what behavioral strategies they're using to manage their CDH diagnosis and interest in type of interventions. Then they did focus groups to uncover themes related to quality of life with hypersomnia and what would you like in a treatment. It was very patient-centered, which was a lovely way to develop a treatment. And then they did a small study testing out this treatment, CBTH. They developed the study, which I'm going to show you what the components are now. It was a small study with 35 adults with either type of narcolepsy or IH, and they had 6 sessions, either one-on-one with a provider or in groups. And they found that CBTH decreased depression symptoms and that the group format was very effective. This was before COVID when group and virtual formats were a little bit more difficult to do. And there was a high acceptability amongst patients about liking this, enjoying being in this group, and what they got out of it. So this is from the study looking at the CBT modules and activities. And so there's a lot of different, really great intervention here. So first, just education about hypersomnia. And, I'm always surprised at, patients who have had narcolepsy for years or for decades still don't have a lot of education about it, or people who have a new diagnosis maybe don't have it. Self-identity and self-image, structured daytime activities, structured nighttime activities. So the daytime activities, kind of using the diaries to define a structure for the day, using the Pomodoro technique, which is a way to pace our activity and rest during the day. People like that a lot. Making sure that, the nighttime sleep experience is as good as it can be. Talking about coping skills and emotion regulation, social support. I love the module on medical, legal, and occupational issues. That's not something in mental health that we usually have to work on with people. But as you all know, that's a very important part of managing hypersomnia, is understanding how it's going to interfere with very realistic functioning. Then there were other topics that could be included as appropriate for the patient or the group. Now, at the Cleveland Clinic, was really interested in doing this. We have a very large population of patients with narcolepsy type 1 and 2 and IH. I know Dr. Nancy Fulberry was able to speak with you yesterday, and she has helped me tremendously in diving into this work. So we had a lot of patients to potentially enroll in these CBTH groups, and we had 3 or 4 patients a group. Every group I tried to get all diagnoses represented. So type 1 narcolepsy, type 2 idiopathic hypersomnia. We would do 6 weekly sessions. We would do it via group. We would do it telehealth. Now, patient takeaways. In general, the takeaways I got was that they did not want, my patients did not want tips and tricks for managing their sleepiness or managing their wakefulness or wake time. They didn't want me to cure their hypersomnia, which was a relief because I couldn't. But they really just wanted someone to listen, myself and their other group members, who knew what they were talking about. Most of them didn't have another person in their life who had a hypersomnia condition. Their family, their friends never heard of it. So certainly there's a lot of stereotypes that they had to overcome. They talked about sleep inertia And so we talked about strategies for that. We talked about productivity for those who were still working, how to do work. We talked about disability and accommodations. A lot of people were working through disability. But those last 3 bullet points there were the things we talked about the most: loss, grief, loss of careers, relationship, health. There's a lot of anger. There's a lot of anger over the loss or not being able to start something at all. That loss of their dreams in terms of going to college or having careers that they wanted. And talking about relationships, a lot of loss and grief and relationships not being what they wanted to be. So with these experiences with CBTH groups, I saw an opportunity for innovation rather. Focusing on focus on people's experience with CDH and living the best life possible, not aimed at problem solving, not aimed at symptom management, not aimed at hacks to get around how they're feeling during the day and at night. And we have a treatment in mental health that we use very commonly for people who have chronic illness, incurable chronic illness like hypersomnia. And it's called acceptance and commitment therapy, or ACT for short. And ACT has been studied in chronic pain, cancer, MS, you name it, it's been studied in it. And I started to think, my patients with hypersomnia disorders, they fit. This is a chronic illness. They fit this same mold that some of my other patients with chronic illness fit. And I think that they would benefit from this more than me trying to help them manage their symptoms. So let's talk more about what ACT is. I think most therapy, psychotherapy, when you go see a therapist, is really based on the serenity prayer, right? So we all know the serenity prayer. Grant me the courage to change the things I can, the serenity to accept the things I cannot change, and the wisdom to know the difference. And really the work of therapy is understanding the wisdom to know the difference between what I can control and what I can't control. And with ACT, it's about learning that the more you struggle to fix what cannot be fixed, the more you suffer. So the more energy you put into the things that you cannot change, the more you suffer. So Dr. Munt passed out some finger traps here, these wicker finger traps. I'm sorry, the light's so bright I can hardly see you guys, but hope everyone got these. Put them on, put them in your finger. Has everyone used these before? I used to get them from Chuck E. Cheese when I was little, but right. So if you haven't used this before, you might be a little like, how do I get my fingers out? Someone shout out, how do you get your fingers out of this? Do you keep pulling really hard? You stop pulling, you stop fighting, right? Right? And that's what ACT is. ACT is all metaphors. So I'm going to continue to do metaphors, but this is one of the most famous metaphors of ACT. Is there are problems that can't be solved by continuing to fight and struggle. And just like the finger trap, you can pull and pull and pull and fight and fight and fight. Your fingers aren't getting out unless you break it, right? But that's not always possible, right? You have to stop fighting the trap in order for your fingers to let go. So a couple of other tenets of this treatment ACT. ACT is about experiential avoidance. It's about identifying experiential avoidance, which is avoiding a situation or certain emotions or trying to escape an experience that makes you more mentally averse to the experience. So trying to avoid the difficult emotions that you might deal with when managing hypersomnia. So it's about identifying experiential avoidance and then working on strategies to help avoid experiential avoidance and embrace. So with that, we are accepting. So accepting does not mean giving up. And I take a long time to talk about this. It's not, oh, I have it, there's nothing I can do. Life is terrible. It's not about giving up. It's the opposite of experiential avoidance. It's willingly engaging with your symptoms, living parallel. I have hypersomnia. There's not much that's going to change that. So instead of fighting against it, I'm going to live parallel with it. How do I live the best life possible with the disease that I have? And choosing, rather than living in opposition, choosing to live parallel and taking action. Let's take steps to go in the direction you want your life to go. So I have another very popular ACT metaphor that I want you to think about your own experience as we're walking through this. So this ACT metaphor is called passengers on a bus. So imagine you're on a bus and you're the driver. And this is your bus. Only you can drive it. You determine the speed and the direction. Down the road ahead of you is a life you love, full of all your values, relationships, challenging work, contributions to the world. And on your bus are a bunch of passengers. These passengers are made up of your thoughts, your emotions, sensations, and memories. They have all hopped on your bus at some point in your life. And some of these passengers are helpful and they happily come along for the ride. They're coming along the ride towards your values. And these passengers don't bother you. But unfortunately, you have other passengers that are much meaner, bossier, and louder. And they tell you when to turn left, when to turn right, when to stop, and when to go. So let's say you have this one particular bossy passenger. Let's call them hypersomnia. Hypersomnia comes right up to the front of the bus to tell you where to go and how to go there and how to get there. And this passenger is persistent. They will not leave you alone. They are continuing to harass you as you're trying to drive towards the destination you want. And they're very loud, and it tells you you're not good enough. You're not good enough to keep going to that destination of success or your values. And it tells you, you can't drive without my directions. So this passenger is so bothersome and horrible, you try to keep them quiet. You do everything you can to appease this loud hypersomnia passenger. And you can see here, she's in the front of the bus. So you might do what they say. They offer you a deal. Follow my instructions and I will stay quiet. And in the short term, this works, but hypersomnia doesn't stay quiet for long. So while you're focusing hard on making sure you're doing what this passenger says, how much progress are you really making down the road? You may fight with your passenger to keep it quiet. You can argue or reason with it or plead with it to leave you alone. If you could just win this argument, they might be quiet or they might get off the bus. But do you ever win the argument? No. Does your passenger ever run out of time or energy to argue with you? Does your hypersomnia ever run out of time to bother you or argue with you? No. The more you fight, the more energy and focus you give the passenger until you get worn out and you're like, I don't care, drive me wherever. We don't have to go towards the things I want to go towards. What happens if you listen to your passenger? You get farther away from your intended route towards what's valuable. With acceptance and willingness, as you can see, she moved to another seat on the bus instead of the front. With acceptance and willingness, you acknowledge that the hypersomnia passenger is on the bus. It's there, it's loud, you can't kick her off, but you keep hold of the steering wheel and you continue driving towards your values. No matter the passengers on the bus or how loud they are, you are the driver and you choose the route. The hypersomnia passenger is still who they are. You're not changing them. They're still loud and obnoxious, but you say, this is the route we're taking. This is the route I'm going to be on, and we're going to move in this direction. So when we're talking about what are we actually doing in ACT to help you with acceptance and willingness, we talk about the ACT hexaflex. There's 6, I guess, techniques or things that we're going to go through. And I'm just going to give you some ideas of what we might work through in an ACT treatment. Another saying in ACT is pain is inevitable, suffering is optional. The pain of hypersomnia is inevitable. It's not good, but suffering with it is optional. And the suffering is what we're trying to work on with ACT. So in order to get to this idea of psychological flexibility, which is the ultimate goal of ACT, we do things like thought diffusion. So observing and noticing your thoughts as pop-ups on your computer screen. Stop, pause, notice, name the thoughts, play with language, repeat it over and over again. A lot of what ACT is based on like theories of language where we assign value to language, right? Words are very powerful. And so part of ACT is taking those negative thoughts and distorting them in some way so that they have a different feeling. So one of the ACT techniques is sing your thought out loud in a silly voice. You know, I'm not good enough. And then it sounds ridiculous, right? It takes away the power from that thought. Question yourself, is this thought helpful? What if you buy into this thought? If you believe this thought 100%, what's going to happen? And then moving on to another part of the ACT hexaflex is what we were talking about with the bus analogy, was this idea of chosen values. What matters to you in life? How does that guide your actions? And this is a very central part of doing ACT, and something that I talk to my hypersomnia patients about right away is what's important to you at life. Building your values compass, talking about values versus goals. You know, a value is being a good parent. You never check a value off a list. You're like, I'm done being a good parent, right? That's probably always, I hope, always something that you're trying to strive towards. A goal might be, I'm going to go to all of their soccer games, or I'm going to go to their soccer game this week. That's a goal versus a value. A value is never ending. And there's lots of domains of values, as we can see here. And I go through all types of values with people. I don't just say, what are your values? I help them explore that. We sometimes call this a value sort. It's kind of like a card deck with values, and we sort them by like importance, not importance, maybe in the middle. When people are behaving in opposition to their values, that's where distress comes in. So if your value is to be a good parent, but you avoid going to those soccer games, or you miss those recitals, or you can't play with your children, your value and your behavior are in opposition to each other. And that's where distress happens. And then committed action. Pursue what's important to you based on your values. So putting values into action. And this is where I think it's helpful for my patients to have a psychologist, a practitioner who knows a lot about hypersomnia disorders, because putting values into action is very difficult. And especially, I understand the challenges and the barriers that people have when they have a hypersomnia condition. So for example, a valued action might be, I want to learn and develop as a person. So I want to go to college. That might be a valued action. You might protect yourself. You might say, I need to take care of my symptoms first. You know, my sleepiness is, You'll never be able to concentrate while sleepy. You're going to improve your sleepiness first and then go to school. And there might be a degree of, symptom management that you want to have before you go to school. But if that's the way you think, insomnia wins. Insomnia comes to the front of the bus and turns that wheel so that you're not pursuing your value. So the passengers on the bus metaphor is what we work on there. Finally, I just wanted to say, I know a lot of you will inevitably ask, where can I get this done? Where can I get this treatment? Where can my loved one get this treatment? How do we access this treatment? And as you might know, behavioral sleep medicine providers, especially behavioral sleep medicine providers who are knowledgeable about about hypersomnia conditions, we are very rare. However, ACT as a treatment is not rare. ACT as a treatment is something that many, if not most psychologists or therapists will know how to do. So if this sounds interesting to you and you're wanting to pursue it, but you don't live in Cleveland and can't come to see me or see Dr. Munt or some other BSM provider, then finding a health psychologist, they would probably be trained in how to do this for other health conditions. And it is very like I said, I have all these manuals on ACT for pain. If I were to go in and just replace pain with narcolepsy, I think it would all be the same, because it's really a lot of the same experiences with mental health and values and committed action. But I wanted to show you this book. This is one of, I think, really the first patient oriented self-help book for ACT. Most psychologists have it on their bookshelf. I know I do. I use these examples all the time, but it's really not, it's not a textbook. It's a thin little workbook, and it's really for you to work through yourself. So I want to give you this resource. Stephen Hayes is sort of the founder of ACT. He's certainly the most prolific writer and teacher of ACT. So anything that has his name on it is probably very good. But this would be a great book for you to get and work through or suggest to someone else. And that is all. I don't think we have time for questions, but I'm open to questions.
So I know you kind of mentioned like about finding a provider that does this, but like, is there anywhere that we can go specifically to look up in our area for doctors who do this, or like our psychologists that do know a lot about hypersomnia or sleep?
Sure. So for just a general psychologist or a health psychologist who knows how to do ACT, probably the best resource you have is Psychology Today, which is a magazine, but online they have a provider directory, and providers, they have to say what treatments they're competent in and what they're willing to deliver. Now, like I said, a general psychologist may not know a lot about narcolepsy or hypersomnia conditions. So you might be teaching them some, and I know people feel differently about having to teach other people about hypersomnia, but they would know how to do ACT, and it would still be helpful. For behavioral sleep medicine providers, there is a couple of resources to look to see if you have one in your area. There's the Society of Behavioral Sleep Medicine, or you'll hear us call it SBSM. They have a website. It's called behavioralsleep.org. And they have a provider index or a provider listing. And then Dr. Munt, is the PEN one just for insomnia? Is it for BSM providers? Oh, okay. Okay. And what would the search term be for that? Like just CBTI directory? CBTI.directory. So CBTI is CBT for insomnia. And so this directory started out as a directory for people who knew how to do CBTI, but now it includes all sorts of BSM providers.
We do have a question from online. I'm going to paraphrase it for them.
Sure.
Because you kind of hit on it a little bit.
Yeah.
I know you said that ACT is kind of a universal framework to be leveraged. Is there anything that patients can guide their practitioners on around ACT specifically for sleep disorders? Because it's a framework, but every framework has its nuance. Is there any nuance they should point out as they go to adapt that?
Sure. I think the hardest one is what is talking about what productivity and energy feels like for you, especially so for not just sleep disorders, I'm talking about hypersomnia specifically. As far as committed action versus values, you might have to walk them through what you're capable of doing, or what you feel capable of doing in terms of, maybe your value is exercise and physical fitness, and you used to be someone who went to the gym all the time, and that feels just really difficult based on the symptoms that you have. That might be something you have to explain better to a more general practitioner. Because a more general practitioner who's maybe doing this for depression is saying, okay, just do it, just push through, just do it, just forget about how you feel, just push through and do it. And that is sometimes a good advice for different mental health or health problems, but not always good advice. So talking about just the realities of the barriers that you face might be some education that you have to do with a general provider.
Anyone else in the room have any questions?
Hi, I just had a comment. Most providers, you talk about how the patient probably has to educate them. Most of the time, don't you find, though, if you refer them to like the Hypersomnia Foundation website, a provider will do some of their own research, don't you think, so that it's not all, the burden isn't on the patient?
Sure. Yeah.
Yeah.
No, that's a great idea, is the how well researched and organized your website is, and the peer support that you guys have developed is, yeah, let me point you towards this. Let me point you towards this resource so that you can learn a little bit more about it. So yeah, the onus is not on the patient to take the time during a session to teach the practitioner about the basics of what the condition is, but certainly feeling comfortable teaching the practitioner what they experience is really important.
Sure.
But that's a great point, is that there are lots of resources now from the Hypersomnia Foundation and other groups where it's a handout for practitioners. It's
Right.
a handout. And this is, even the most well-meaning practitioner may have biases or stereotypes about these conditions. So that's a wonderful idea.
Yeah, so the patient doesn't feel overwhelmed that they have to explain everything.
No, yeah, and I know that's
It's
difficult.
daunting.
It's like, having to do that for every practitioner who isn't your sleep doctor. That's challenging.
I just wanted to share for anybody local that UW Medicine Psychiatry on Roosevelt has a really great class to learn ACT. It's a group session with Dr. Cox.
Well, unless there's any more questions in the room, I think that's it.
Okay,
Thank you
guys
very
for
much,
having
Dr.
me. Thank you
Roth.
so much.